So clinical reasoning is a systematic and cyclical process that guides clinical decision making, but particularly in unpredictable, emergent and non-routine situations, and leads to accurate and informed clinical judgment. And that statement was produced by Hoffman 2007 and Levitt-Jones and colleagues 2010. The definition that's been provided by the same authors is that clinical reason is defined as the process by which nurses and other clinicians collect cues, process the information, come to an understanding of the patient problem or situation plan, and implement interventions, evaluate outcomes, and they react on and learn from the process. So putting that into everyday language, the reason we're looking at using clinical reasoning is we want our nurses to be thinkers. We want future registered nurses to be able to look critically at the care that they're providing to their patients, particularly in relation to preventing deterioration. The new clinical reasoning model is made up of 7 different steps. And later in this video, you're going to see a scenario involving a clinical tutor and 2 nursing students on the ward actually using the clinical reasoning process and actually going through each stage, so that you as the student nurse will be able to view this scenario, so that when your clinical tutors visit on subsequent visits, you will have a good idea about the format that they'll actually be using to run their clinical visit. So what I want to do now is I want to show you the actual clinical reasoning cycle and briefly explain the different parts of it. So the first part that you can see in the cycle is considering the patient situation. So that's where we actually look at describing the person, what the situation is, and the reasons why that person actually has been admitted to hospital. Or if you're seeing them within primary care, why have they been admitted to the service? Following the patient situation, we're then going to be moving on to looking how we collect the cues. When you view the video involving the scenario, involving the 2 student nurses, you'll see quite clearly how the student nurse went about collecting all her information, which she was then able to process and come up with a nursing diagnosis so that she could then actually plan, set goals, and ultimately evaluate the care. So when we talk about collecting cues and informations, we're talking about reviewing the current information, gathering new information, and recalling knowledge. So when we talk about recalling knowledge, we're talking about looking back on past clinical experiences and being able to link those to our current patient. One of the largest sections is the processing of the information. And that's actually made up of 6 subsections, which we want you to try and consider when you're actually looking at putting your information together. Those different sections are interpreting. So when we talk about interpreting, we're asked the question, are there the cues that we've collected, are they normal for this person, for the time and the place? We move on then to discriminate. The important thing about when we get to discriminate is that we actually distinguish the relevant from the irrelevant information and be able to identify those needs which are a priority for the patient. Then we move on and we look at relate. And relate is when we look at basically joining up the dots, putting 2 and 2 together, and being able to try and actually identify what the main problems are. With regards to the infer, which is our next section under process information, we're talking here very much about being able to thinking about all the information that we've gathered up to now and being able to come up with some conclusions and some opinions about what's actually happening with the patient. When we move on to talking about matching the current situation to past situations, we may be thinking about situations that we've experienced before and what this particular situation might be similar to. And lastly, to do with process and information, is predict. That's being able to predict an outcome. What is likely to happen to my patient based on the information that I've gathered so far? The next major section in the cycle is identifying the problem in the issue. This has been able to pull all the information together that we've gathered under the section where we collected the cues and processed the information so that we can actually come up with a nursing diagnosis. And we need to remember as nurses that we are here to formulate nursing diagnosis and not medical diagnosis. This in a way is very similar to the nursing process. So obviously following identifying the problem in the issue, we're then going to move on to looking at establishing goals. We want to be able to make sure that our goals are based on the SMART theory, which is specific, measurable, achievable, realistic, and timed. So once we've established our goals, then obviously we want to go on to taking action. And this is where us as nurses, in conjunction with our colleagues, we can actually sit down and we can clearly document all the interventions that are required to be able to try and prevent a deterioration in this patient's condition and their subsequent improvement. Once we've actually been able to carry out the nursing care, we then want to be able to do our evaluation. Has the interventions been effective? Have they not been effective? Is the patient improving or are they deteriorating? And lastly, in the clinical cycle, is the importance of reflecting. We need to sit back and we need to say to ourselves, what did we learn from that experience? What do we take away from that experience that is going to have an impact on our future nursing career? So those are all the stages involving in the clinical reasoning cycle. What you're going to see now is the scenario, which I outlined earlier, involving the tutor and the nursing students. We would encourage you to watch the scenario, be able to identify how the two students are using the various parts of the clinical reasoning cycle, and to look at ways that you can actually utilise the cycle within your everyday nursing practice. Right.
Hi,
It's
Michael.
nice to see you again.
Oh, thanks. Nice
So,
to be back. Good to see you.
What sort of week have you had?
Oh, not too bad. I think it's adjusting to the ward environment. It's nice to be back after a break. Yeah.
So just remind me, which week are we on now?
Second week of
Second week of
Oh, it's gone really
yeah.
quickly, hasn't it?
It has. Yeah.
So are you enjoying medical?
Yeah. Yes, I am. I'm really enjoying it. Yeah.
Starting to feel a bit more comfortable
Yeah,
with the staff.
It's what I really want to do. So yeah, I'm enjoying it. Yeah.
Are you finding that you're able to begin to sort of like use your knowledge that you learnt in school before you came onto placement?
Yes, I'm starting to relate. I think my theory to practice slowly.
So I suppose the main thing is just to try and ask both of you, have you got any problems or any worries about your first couple of weeks? What about you, Joylyn?
I think this week's better than last week. I'm starting to understand the ward routine a bit better. It's a little bit different from our surgical placement, how they run things. Yeah, I'm feeling a bit more comfortable this week actually, rather than my first week.
That's really good. And you're smiling, which is a really good thing. And the feedback that I've got from the nurses when I got here a bit earlier was really, really good about the two of you, which is really, really pleasing. I hope you don't mind that I asked to meet with the two of you together today. I just thought it would be quite a good opportunity, and you could share experiences with each other.
Okay.
Yeah, I think that's a great idea, yeah.
So you remember last week when we met, we introduced you to the new clinical reasoning cycle.
Yes,
And I think you may have been given one of the little laminated cards that shows you exactly what the clinical reasoning cycle is. And last week we spoke about you identifying one of your patients who you could present today using the clinical reasoning cycle. And I thought what was really good was that you remember when I texted you both during the week, you asked me if it would be possible if you could split your feedback regarding your patient and do half each. Was that something that you still wanted to do?
Yes, I think that's a
Give it
great
a go,
idea. You want
yeah.
to see how we go, yeah.
Just before we start with that, what is your overall thoughts about this new clinical reasoning cycle?
I think it's going to take a little while to get used to, because we're so used to just presenting a patient, but I think it's a positive step forward, I think.
Okay,
I think it makes you think about what you're doing and why,
that's exactly what it is, yeah.
and I think it helps you plan for your day better, for your shift better, because you've kind of like a clear plan of what to do, so it kind of helps with your confidence. That's what I'm finding.
And what do you think the overall aim of the clinical reasoning cycle is when it comes to patients' welfare?
I think it's making sure you've got the information available and you've researched it and you've got the steps in place to ensure patient safety.
Yeah, exactly right.
Yeah.
It's all about trying to prevent the patients deteriorating. And it's about you being able to look at the much wider picture and being able to be more critical thinkers
Yeah.
rather than just carrying out nursing tasks without actually doing a lot of thinking about it.
So not monkey see, monkey do.
Yeah, that's a good way of putting it.
Yeah.
So, who's going to start?
I'm going to start
Okay, Joylyn.
today.
So what I'll do is let you go through, I believe you're going to do the first half.
Yeah, I've got a plan.
And then Alex is going to take over and do the second half. And maybe what I'll do, if it's okay, is as we go along, if I can think of a couple of little questions that will help you reflect on your practice, I'll maybe chip in. Is that all right?
Yeah, that's fine.
Okay,
by me.
great.
Okay, so my patient is called Mr. Johns. He's 74 years old. He was admitted to ED this morning at 5:30. He was brought in by ambulance on the 16th of February. He presented as being short of breath and slightly confused because he'd had a fall at home.
Okay.
He had no skeletal injury, no bruising except some on his buttocks, and no loss of consciousness as we're aware. He's got limited mobility, Michael, because he's got really edematous legs and feet, and his edema comes up to his hips.
Oh, that can be a real problem,
Yeah,
especially in terms of increased dependency, can't it?
yeah, exactly, and his age being 74. He actually lives alone. He lives out on Arahi Way, but I found out he's got family in Auckland.
Okay.
And they're also able to establish an ED there. He is for resus.
Right, and that's a really valuable thing to pick up on, isn't it?
Yeah.
Why do you think that's so important that we establish that sort of quite early?
So if he has a critical incident or he deteriorates, then we know what we're going to do.
Exactly.
We're going to do life-saving measures for him.
That's right, and it's about taking the patient's wishes into account, isn't it?
Yeah.
So that's really good that you managed to pick up on that.
Oh, thank you. And then so since he's come on the ward, I'm caring with him with my preceptor, my RN, and he got admitted to ward 14 at about 10:30. So straight away we did some vital signs, and his blood pressure was 90/60, so it was a little bit low. His respiration rate was 24, and he's come on 2 litres of oxygen. He's got nasal prongs on, but his SATs are at 95%. His temperature was normal, 37.2, and his heart rate, Michael, was 88 beats a minute.
Okay.
So he's actually scoring as early warning score, an EWS of 6.
Which is quite high, isn't it?
It is
Really?
quite high, yeah. So we're aware of that. He's got an indwelling catheter, and they put that in an ED, and he's had about 800 mils of urine pass since 5:30 this morning.
Good, that's good detail. And that's the sort of thing that we're looking for when you're doing handovers, that you're actually being quite factual,
Okay.
rather than, for instance, just saying his catheter's draining all right. Because at the end of the day, what does all right mean?
Yeah,
So that's really
true.
good, so that's good detail.
Okay, we also did a 12-lead ECG because of his history. He's got some heart failure, but the health officer had a look at it, but they couldn't see any changes from his previous admissions, so that's not ringing any alarm bells at the moment. He's still actually a bit confused and anxious, and I think he's confused and anxious because he's quite short of breath.
Yeah, exactly. So what would we call that? You're saying he's short of breath, he's a bit confused. What would be sort of the medical term that we would refer to?
Do you think it's hypoxia?
It is. Definitely sounds like it is. And obviously, what do you think could be the reason for his anxiety?
Because he's fallen, he's in a foreign environment, he doesn't know what's happening. Maybe because his oxygen saturation's low, he's not thinking as clearly as he normally would.
They're very good answers.
Maybe.
That's exactly right. And we often find, if you look at the literature to do with heart failure, anxiety and dyspnea are really those two big things that sort of stand out.
Yeah, okay. So what we've also done with my nurse, because I'm just learning how to do it, the falls risk assessment.
Good.
And we've done a pressure area key assessment because he can't move in bed because he's got so much fluid on board, so we're trying to prevent any pressure areas developing. Did you want me to tell you some of his past medical history?
Yeah,
Michael?
that would be great.
So he's actually got history of hypertension and gout, and he's got heart failure that we know about, but he's also known to a medical outreach team. He's on medications, he's on beta blockers, and normally at home he takes frusemide in the morning.
Right.
He takes 80 milligrams, he takes 40 milligrams at 8 o'clock and another 40 milligrams at midday. And he's on a medication to lower his cholesterol, and he's on medication to help his gout. He's also on an ACE inhibitor, citalopram, and he's on a maprazole, and he takes 20 milligrams BD.
So what do you think, what's the main purpose of an ACE inhibitor?
To keep his blood pressure low.
That's right.
Causes it to dilate the capillaries and arteries. But Michael, do you think that's a problem now that he's actually hypotensive, he's got low blood pressure, if he's still on that medication?
Why do you think he's possibly hypotensive at the moment? What could be a couple of things that's maybe going on?
I wonder if they've put an IV on him to get rid of that excess fluid, and
Right.
it's got frusemide in it.
And what's the frusemide ultimately going to have, what effect is it going to have on his blood pressure?
Lower his blood pressure
It
because he's
is.
getting rid of more fluid.
Exactly.
Yeah.
And the other thing is, this man's come in with an exacerbation of heart failure. What could have happened to his heart muscle in the meantime?
Got weak.
Exactly. His heart muscle has become a lot weaker, which is ultimately, what effect is that going to have on his blood pressure?
It should make it lower because it's not got
Exactly.
the same volume of
Exactly.
contraction.
And when you're doing your reading, what you'll find is, in the extreme situations, if somebody comes in and they've got severe left ventricular failure, is that you can end up with cardiogenic shock, which you've read about, which obviously will cause the blood pressure to drop quite significantly. So that's a really good observation.
Okay, so we'll just keep monitoring his blood
Yeah,
pressure,
exactly.
I guess, when we do his EWS. So I suppose now we kind of like recall what knowledge we know in terms of the pathophysiology for him. And I know he's got the pulmonary edema because he's got a bit of a cough and he's got some shortness of breath, so he's got lots of fluid sitting in his lungs, which is to do with his left ventricular failure.
Yeah, do you want to try
Is
and
it-
do you want to have a go at maybe trying to explain that to me? What's happening with the pulmonary edema?
He's getting a build-up of fluid in his lungs because his heart's not pumping correctly, and it's making his oxygen saturation drop.
That's right. So where's the fluid getting forced out of?
I don't know.
Okay. So what are those tiny, tiny little air sacs at the end of the main sort of like bronchuses in your lungs?
Oh, alveoli.
That's right.
Yeah.
So what's happening is that they're becoming so dilated, the fluid's getting forced out of them, and the person's actually ending up with fluid in the lungs, which is obviously causing this problem with the pulmonary edema,
Yes.
which is obviously why this man who you're describing to me is so short of breath, and he's so anxious. So
Yeah.
ultimately, we're hoping that the furosemide will help actually get rid of some of that excess fluid.
So we've got kind of two problems though, don't we? Because we're trying to treat it, but we're also causing a low blood pressure.
Yeah, exactly. So it's trying to sort of balance up the two things, really.
Yeah. It's quite a tricky one, isn't it, for the patient? That's all I can think of.
Would there be any other drugs that you could think of? So this man's come in this morning, he's really anxious, he's really breathless, suffering from dyspnea. Is there any other acute type medications that we could maybe ask the doctor to prescribe that might help with his anxiety and with his overall shortness of breath?
Could maybe think of something like diazepam.
Yeah, that would
Something
be
short
exactly.
acting. It won't actually reduce the shortness of breath, but it will reduce his anxiety. That's something I could think of, maybe something like that.
That's right, and I've seen while I've been on the ward here occasionally that they're now using intranasal midazolam for people with that sort of problem. So that would be a really good one. Have you seen them using morphine as well?
Yeah, I have. Yeah, that's a good one because I understand that it doesn't stop the shortness of breath, but it blocks the message from the lungs to the brain saying I can't breathe, and takes that anxiety away.
You're exactly right. So morphine, midazolam.
Yeah.
I suppose the other one that I've seen used sometimes is that people will use Brivitral drops, or the other name for it is clonazepam,
Yeah.
which patients can use. So that's really good that you've got that knowledge of those different types of medications.
Okay. I'd have to do some research on the clonazepam. I don't know much about that.
Good.
And then I suppose I was thinking on my plan of care about identifying the problem and the issue, or was that you going to talk about that, Alex? Were you going to take over from there?
Yeah.
Okay. So that's really good. So up to now, you've obviously given us a really good introduction to your patient. And then you talked about how you actually managed to gather all your information together. And then obviously you went on, the last part was how you actually process that information and to actually be able to come up with the nursing diagnosis, which I think, Alex, you're going to talk to us about, aren't
I'm
you?
going to talk about that today.
Right, that's great.
So yes, I've had, been helping out with Mr. Johns as well. So I think I'm going to identify the issues and the problems that Mr. John has encountered or is encountering. So one of the main ones I feel is his shortness of breath, secondary to the pulmonary edema. He's still on the oxygen. He's quite hypotensive, so due to the IV furosemide and maybe a bit of decreased cardiac output and left ventricular failure. So that's one of the main problems. Also a bit of decreased level of dependency, and due to the edema and shortness of breath, due to the swelling up to his hips, he's not mobile at the moment, so he's needed quite a bit of assistance with that. He's also quite anxious and confused due to his low oxygen saturations, a bit of hypoxia there, and also because he is currently not able to get out of bed and mobilise, and he's feeling a bit,
What else could he
isolated.
potentially be at risk of? You said that this man's come in and he's very immobile. He's obviously got an increased level of dependency.
Yeah.
He's got this huge amount of edema. He's not moving much at all. What potentially could he be at risk of?
Maybe a DVT.
Yeah, exactly.
Um,
Which could lead on to what?
Pulmonary embolism.
Yeah.
Yeah, I think he may be on some Clexane, or they may look at putting him on some Clexane just to
So why would
prevent that.
so what's Clexane? Why would you put somebody on that with a risk of developing a DVT?
It just helps to thin the blood slightly to
Right.
prevent blood clots. So.
Good. So that would be a really good
Yes.
like prophylactic type measure, wouldn't
Yes,
it,
I
to
think
stop
so,
that?
Yeah.
No, that's great.
Yeah.
So what else have you got there?
Also, maybe an increased risk of infection because he has got an indwelling catheter, and he's also risk of infection due to the swelling. He may develop a pressure area on his leg,
Yeah.
and if the build-up is bad enough to have leakage through his skin, he's also could be at risk of developing maybe a cellulitis.
Yeah, because obviously these days we are trying to promote the prevention of sepsis,
Yeah.
which you've done in school, which
Yeah.
is a major issue that can obviously lead to somebody dying.
Yes,
So that was really good that you identified the increased risk of
Yeah.
developing a urine infection with having a catheter in,
Yeah.
because ultimately, if this man was to develop, which we would refer to as urosepsis, he could end up being very, very ill indeed.
And I guess, yeah, we'll look at maybe doing a urine sample if his confusion increased at all, or he became a bit delirious.
Good.
So that's about that for identifying the problems. I think I'll go on to maybe establishing some goals now
Right.
for my patient. So I think one of the main things is making sure he has a daily weight and ensure he is losing weight each day, and maybe a full input and output fluid balance chart, a very strict one.
What's quite an important factor when it comes to weighing somebody on a ward, particularly with heart failure?
Make sure you do it in the morning.
Exactly.
Yes, yeah, I think the morning's the best time to weigh them.
Yeah.
So as soon as they get up.
And have you ever heard of the phrase a dry weight?
I'm not sure if I have.
This wouldn't obviously apply to your man because he's got a catheter in.
Yeah.
But a dry weight is when somebody who's not catheterised, we would encourage them to pass urine before we weigh them,
All right.
because
yeah.
that would give you an even more. But that was good how you identified about doing it at the same time where possible every day,
Yeah.
and that way you can more objectively measure the urine output. Good.
And ensuring that his urine output is maintained above 30 mils an hour.
Right.
Just so he is meeting that EWS standard. Also monitor his confusion and maybe orientate him to the time to where he is, and ensure he's got his call bell nearby. And this will also be relevant with his falls risk, making sure he's got the call bell ready.
So that's good that you're thinking about everyday, straightforward, practical things that we can do as nurses to try and maintain somebody's safety. And some of those things you've just clearly outlined for us there.
Yeah. Also maintaining his pressure areas, making sure his water low. I think Joyland did mention that he'd had a water low done, so making sure he does, if he's not able to move, maybe 2 to 4 hourly turns, or even trying to get him up in his chair, which will also help with his lungs.
That's right, and that is, you were talking before about the risk of developing a DVT. That would be a great thing.
Yeah.
That once you can actually get this person moving, you significantly reduce the chances of that happening.
And even if he has got a catheter, and the more the fluid comes off, the more mobile he'll probably become. So I think, getting him in his chair for his breakfast and lunch would be a great idea.
Good.
Also looking at, he has phoresis, we know that, and also maintaining his oxygen saturations above 95%.
You said before that you're giving him oxygen at the moment via nasal prongs.
Yeah.
What would normally be the maximum amount of oxygen that would be prescribed to give somebody via nasal prongs? How many litres?
4 litres.
Yeah, exactly.
Yeah.
What's going to happen if you give somebody much, much higher flows through nasal prongs?
No, I don't think it would work as well. It would just go elsewhere.
It dries out their nose.
Dries out their
doesn't it?
nose
Makes
as well.
it
Exactly.
uncomfortable.
You're right. So people can end up with really nasty, sore, inflamed mucosa inside the nose. So that's dead right what you said. Generally, no more than 4 litres.
Yep. Also, I'd look at maybe keeping his legs elevated while he's in bed, making sure that it's for the fluid, and keeping his head of his bed at no less than 60 degrees.
So very positional.
Yeah,
isn't
very
it?
positional, because he doesn't want to be lying flat, because he's not going to be able to get that air entry in to breathe with the excess fluid. And also just reassure him regularly and do hourly rounding, just to make sure he knows we're available if he needs us, and we can keep him informed on what's happening.
No, and those are really, we want to obviously do our very best for our patients, particularly this man. And it's a matter of being really attentive to his needs, isn't it?
Yeah.
And you've clearly gone through quite a lot of different things, both of you, that you need to do for this man, which hopefully is going to have an impact on his recovery.
Yeah, that's what we're aiming for. And also we'll look at taking some action of what I'm going to do for Mr. Johns. So I'd report to my preceptor his early warning score and his vital signs. I would explain to her his blood pressure, pulse, respiration rate, oxygen saturations one by one, and his temperature, whether they were normal or abnormal, because whether they're abnormal or normal is it's my responsibility to let my preceptor know, because I am a student. So
I'll give you a little situation. Say this man, when he's at home, normally has an oxygen saturations of, say, 90% or 89%.
Yeah.
Is there anything that nurses can discuss with the medical staff when it comes to the early warning scale?
Yes, so we'll look at maybe talking to the doctor about that and having his parameters altered.
Right.
And getting a good plan in place if that is his normal reading.
Because what we need to do when people come in is we need to look at the baselines, don't we?
Yes.
And we need to, like Joy Lynn went through, gave us a background about this man's history. So that includes looking at things like his vital signs.
Yeah.
And what are they normally?
Yeah, exactly.
So we can, as you quite rightly said, we can have a discussion with the medical staff to look at actually adjusting his EWS. So that's a great point that you brought up, Alex.
I'd also look at SBAR and reporting to my preceptor and then to the house officer my concerns regarding his EWS, and just putting a plan in place for that. I would also contact the medical outreach, because I understand Mr. Johns is currently under medical outreach in the community, and it's good to contact them while they're in hospital, and they can visit them and we can put a plan in place and actually know what his normal is and what has been happening for him in the past.
And that certainly fosters really good relationships as well, because obviously we don't want the team going out to see him, not realising that he's in here, but also what you were saying before is we want to try and make this man's care as seamless as possible.
Exactly.
So we, all being well as a team, get him to a level where he's able to go home. We would like him then to be visited quite promptly by the outreach team to be able to continue that care.
Definitely.
So I think that's a really good point that you brought up there.
And I'll also contact the social worker just to review his social situation. He has been living independently, but his family's in Auckland, so and because of this recent episode of heart failure or exacerbation, I think it's good that we look at maybe putting some supports in place if he's happy with that.
That's great.
Yeah. Or I was even thinking if he, depending how he is on discharge, whether he needs primary options and looking at a few days in the rest home just to get him back on his feet. So I thought we could suggest that to the social worker as well.
They're really good initiatives that you're suggesting, because it's not just about doing the care for this person while he's in here. It's trying to, and this is looking at the clinical reasoning model. It's looking at the much wider picture, isn't it?
Yeah.
And you, as the two of you, becoming critical thinkers and been able to look at all the things that you've just described about how you want to plan for when he goes home, so that hopefully he'll be able to go home without there being any unnecessary deterioration.
Yeah. And also, contacting the house surgeon, I've said that, about his EWS and the parameters. And also looking at maybe the wider MDT while he's in here, looking at the dietitian and the occupational therapist, whether he needs extra equipment at home, and even getting the chaplain in, just in case he needs someone to talk to.
And that's really nice that you brought that up, because again, I think sometimes we can think of all the health, practical type things, but sometimes the spiritual side of care can tend to get neglected.
Yeah.
Would you both agree with that?
Yeah,
So,
I do, yeah.
suggestion like you just said about asking him if he has a belief
Yeah.
and being able to bring the minister in, I think that's a really nice suggestion, and
Yeah.
it just shows him that we're addressing his whole
Whole
person
person, yeah.
and not just the physical side of things.
Yeah. And for my evaluation, I think the main thing would be just to make sure his BP blood pressure is maintained and that it's stable. I mean, if it is going to be at 90/60, make sure the doctor's happy with that, and if it does, and having that EWS parameters altered, and making sure his urine output is maintained above 30 mils an hour, so making sure he's not becoming dehydrated as well because of the frusemide.
Good points.
Also maintaining his fluid balance chart, his comfort, and ensuring he's orientated to his environment, and having the call bell available.
That's very good. So I'm really pleased with all the information that the two of you have presented. I think what's maybe important to do before we sort of finish about this patient is to allow you to give both of you the opportunity to be able to briefly reflect on this patient. So maybe we could start with you, Joylyn. Just a few sentences, if you can think of what you've actually got out of looking after this patient, and what sort of impact do you feel providing this care will have on your nursing career?
I suppose for me as a student nurse, I was thinking that by having the time to gather some information, I actually felt a bit better equipped when I knew what had happened to him at home, that he had a fall, a bit about his past medical history, that he lives alone, and how he was in ED, and by taking vital signs when he arrived, it kind of gave me a plan to know what I should be looking for as a nurse, and what I should be focusing on. And it helped me communicate with my RN better, my preceptor better. So I suppose it just gave me, the more knowledge I gathered, the more confident I felt.
And certainly, when I listened to all the information that you presented about the man's history, all about his presentation when he came into hospital, it certainly put you in a very good position to be able to then proceed to plan the care for this man in a real holistic manner. And that was really evident when Alex, when you were talking about how you were going to actually go about planning the care and actually looking at goals. If you hadn't have done the preparatory work, it would have been very difficult indeed for you to be able to do that.
Oh, definitely, yeah.
Sorry,
Sorry, I was just thinking something else that we probably could think about for this man is, why did he fall at home? Is there a hazard in his home that we can look at fixing? Maybe when his family come up from Auckland, we can get them to check he's not tripping on a rug regularly, or maybe it's something we can prevent. Maybe it's not. Maybe it's just because he had that oedema and excess fluid, and that's why he tripped. But just thinking about how we can make it safer for him to be in his own home.
Good. Was there anything you'd like to comment on before we finish, Alex, about anything you'd like to reflect on?
I think that doing this cycle for the first time, I think it's really helped me to see how much information you do need to have about your patient, and to be how prepared you need to be. It's not just about writing down when they need a shower or what medications are on. It's about looking at the big picture and what's actually happening with your patient, and be prepared if the patient does deteriorate. And I think it's an excellent process.
Well, I'm really pleased how the two of you, because we only introduced you to the cycle last week. I've been really pleased how you've actually taken it on board, and how the two of you have actually picked this patient during the week and actually broken it down into the different steps to present to me today.
Oh, thank you.
So I think you're both doing really well. I'm really, really pleased with you.
I think the lemonade cards have helped us heaps because you
Okay.
have that visual reference
Yeah,
to
definitely.
refer to. Do you agree?
Yeah.
So it would be good each week when I come if we could maybe continue using this same model.
Yeah.
Okay.
And I'm sure that it will help increase your confidence
I think it
as you go
definitely
through
will.
this placement.
Yeah, I think it will be great. Thank you.
So thank you for meeting with me today, and I look
It's all
forward
right.
to seeing the two of you again next week.
Thanks.
Well, I look forward to it
Thanks.
All right
myself.
then, thank you.
Thank